vasovasectomy, vasovasectomy. There is, in this case, epididymovasectomy is also an option. If there is azospermia after a hernia repair, then a high approach or inguinal vasovasectomy is an option as well.
Which of those do you think? Which one would you advise the couple to have?
Considering his epididymis was rather full, and if the distance between the proximal and distal end of the shaft is not too long, then I would recommend vasovasectomy plus aspiration of his sperms.
Okay, so you're okay. Is that time?
Yeah. Yes.
Okay, let's just go back. Right. So at the beginning, you got flummoxed because it's a vasectomy reversal. So how do you assess him? It's a fertility patient. So you assess him in exactly the same way. So you've got to take a focused history about all the fertility risk factors. You don't even know if he's got children. He may have never had children. So he may always have been sterile. I mean, not sterile, but he may have always been azospermic. So you need to ask him, when he had the vasectomy, all the things you said were right, but it needed to be fuller and it needed to be more structured. So you're going back and forth. So what I would do is I would ask him why he wants the vasectomy reversal. When he had it done, were there any problems when he had it done? And then I'd ask him about his fertility. I'd take a focused fertility history. Has he had any children? Has he had any difficulty conceiving? And then risk factors. Has he had any inguinoscrotal surgery? Have you had any chemo radiotherapy which might have affected it? Does he have a history of undescended testes or torsion? Is he on anabolic steroids? Has he had any drugs which may have affected that? Does he have normal erections and ejaculation? So it's still got to be a focused fertility history, regardless of the fact that he's coming in for a vasectomy reversal. And then you're going to examine him. Don't forget, this is a fertility question. So you want to look at him first. Does he look like he's hypogonadal? Yeah.
Okay.
So I would just say that I'd say on examination, I'd look for signs of hypogonadism. They might ask you what sort of signs. So, central obesity, gynecomastia. He may have an abnormal distribution of body hair for a man. And then you're going to examine the scrotum, the external genitalia. You're looking at the penis. Does he have any congenital abnormalities which might affect ejaculation or semen coming out, such as hypospadias? You're going to fill both testes are they normal volume, which is what you expect in most vasectomy patients. You would expect the epididymis to be dilated because he's had a vasectomy before. Then you're going to try and see if you can fill the gap in the vas, and you want to document, if you can, where that gap is. Is it close to the testes or is it further away? Is it a big gap? Some urologists really try to make sure that these guys can never have children. So they'll take all of the vas pretty much, and then they burn everything that's left. Obviously, don't say that. So those are the sort of things you have to talk about. And then what affects the vasectomy reversal? You're right. The length of time between when he had it done is probably the most important thing you have to say, but also the gap, how the vasectomy was done can affect it. If they've diathermied the ends, both ends, and the patient may not know this, but you have to mention it, the chance of you being able to re-anastomose those two cut edges it's going to be a much more difficult operation. The other thing is how big is that gap between the two ends of the vas? If it's a big gap, it's going to be difficult to pull it together and re-anastomose, which means you're going to anastomose onto the epididymis, which is much more difficult, and that reduces the success is much lower with a vaso-epi than with a vaso-vaso. So those are the things that really affect
Can I just ask, the chance of reversal is less than
Yes.
vasovagal?
Yeah. So if ideally you want to anastomose the vas onto the vas. If there's a big gap, you have to anastomose the vas onto the epididymis. Yeah. Which has
So
a
chance
lower
of-
success rate. Pardon?
has a low, so vasoepididostomy has a low success rate.
Lower.
Lower. Okay.
Yeah.
Okay.
Yeah.
Okay.
And the closer it is, the closer the cut end is to the testes, the more difficult it is. That drops off the success rate as well. So you want it to be nice and close together. So those are things that you want to talk about then. And that's why I gave you some of the, and don't forget in the history, you want to know about the female partner as well. How old is she? Does she have any children? Has she been seen by a female fertility expert? STIs is really important for fertility history. And then when I told you about the examination, you know, I said that it's easily palpable in the scrotal neck. That's a long way to anastomose to the one end of the vas to the other end. And then on the left, it's closer to the testes. Sorry, I got it wrong a few minutes ago. So if it's closer to the testes, it's better because you can just pull the two together because it needs to be tension free. If you've got one end in the scrotal neck, you're never going to get that down to anastomose. And the investigation is the same one you would do for all fertility patients. You have to do a semen analysis. You've got to check their hormone profile. Yeah. And that's all you need to do. And you were right about the interpretation. It all looks like obstructive azo, which is in keeping with somebody who's had a vasectomy. Now, what are the available treatment options? So one is a vasovasostomy and a vasoepididymostomy, i.e. a vasectomy reversal. That is an option. At the same time, you wouldn't do a TESE or a TESE, you would do a MESA, which is where you aspirate. So before you anastomose, you're going to cut the ends of the vas off, freshen it up, and then you're hoping that you're going to have some seminal fluid coming out of the cut end that's closest to the testes. Yeah, you would then send that off to your embryologist, who is ideally in theatre with you, and they'll analyze it under a microscope, and they'll say to you, yes, there's sperm, and then you go ahead and you anastomose, and they can then freeze that sample of sperm, because you don't know if your vasectomy reversal will be successful. Or they'll say, there's no sperm, in which case you either cut a bit more or you're going to need to anastomose onto the epi. Yeah. Make sense? So that's one option. Another option is you just say to them, 30 is getting on a little bit for a woman in terms of fertility, starts to drop around 30, 35. So they don't have a huge amount of time, this couple. So they've really got to think about, you know, not messing around with a vasectomy reversal, which will take them, it will take maybe anywhere from 6 to 12 months before you see that the semen analysis has picked up. Assuming you're a brilliant surgeon, everything goes according to plan. Can you still hear me? Hello? Hello? Oh no, it's all crazy. Hello, is anybody there?
Yeah, we're here. I think he lost the connection.
Oh, okay. What was the last thing you heard me say?
We was talking about like the female reserve. That's the last thing.
Okay, so female fertility starts to drop off about 30, 35. It's really 35, but she's not a long way away from that. She's going to lose probably a year waiting for his semen analysis to pick up from his vasectomy reversal, which takes her to 31. Then he may get problems like get Mace stricture, which might take another year out. And then before you know it, she can be very close to 35. So that's something that you've got to realistically have a chat with them about, that maybe the best thing is not going to be a vasectomy reversal. Another option is that he's got obstructive azo, which means the chances are really good that he's got sperm in his testes. So maybe you just do a TESE. Maybe you just do a TESE, find some sperm, and then they can have IVF.
Okay. Yeah.
Yeah. That's another good option. Another option is donor sperm, as you mentioned. And then lastly is adoption. Yeah? Make sense?
So can I just ask, can you just give me the options again? There is sperm
So vasectomy
extraction.
reversal. So
Can you hear me?
vasectomy reversal.
Hello?
Hello? Yeah.
I think works in this hospital, man. In this.
You have to just stop it.
I'll stop it.
Hello?
Hello,
Hello?
Miss Kalaji. I'm very sorry. The reception was a bit bad, but can you just give me the options again for this patient?
Okay, so the first option is a vasectomy reversal.
Yes.
And then the second one would be a teaser.
Okay. So TESE is along with vasectomy reversal at the same time?
No, it would be all. So at the time of
Okay.
your vasectomy reversal, you would do a MESA, which is where you aspirate sperm from the cut ends of the vas
Okay.
before you do the reversal.
Okay.
So you could say to them, time is, is close. Maybe we just go and we take some sperm out of, get some sperm out of the testes.
Yeah.
We don't mess around with the vasectomy reversal, and you can go and have IVF with that.
Okay. Okay.
But that limits their options because they did say they want to have 1 or 2 children.
Correct.
That limits it. The best chance of getting 1 or 2 children would be if you do the vasectomy reversal. But
Okay.
a teaser is an option,
Okay.
or you could do a PISA if you're not going to. So essentially, you can do surgical sperm retrieval, of which.
Okay.
This chap, if he's not going to have reconstruction, you could have a PISA, which is where you aspirate from the epididymis. You could have a TESE, which is where you aspirate from the testes. That's the one gynae like to do. Or you could do a TESE is what we do. A TESA is what the gynecologists do. So a TESA is aspiration. They just shove a needle into the testes and draw back.
Yeah.
A TESE is what we do, which is where you make a small incision in the scrotum, deliver the testes, open the tunica, and then take them gubbins out and send that off to the embryologist.
Okay. Okay.
Yeah, makes sense?
Yes. And then adoption as well is in, should we
Adoption
offer...
is always an option, as is donor sperm.
Thank you.
The next question was, what factors would you consider? I think we've spoken about all of that. Females' age, what they want in terms of having more than 1 child, the factors with regards to, it's going to be a difficult vasectomy reversal on one side, the side where one of the ends is up in the scrotal neck. So success is going to be reduced. And what would you advise the couple? I mean, if you get to this point, it's just a conversation about all the pros and cons that we've just discussed. Yeah.
Okay. Okay. Yes.
Does it make sense?
Yes. Yes.
You sure?
Yes. Yes. Absolutely. Thank you.
Okay. So I think I sent you guys a crib sheet of what's it called? Of my crib sheet for taking a history for fertility patients. Have you got it?
No, I don't think I've received that.
Okay, I will share. Should I share it with you? And then if you could share it with the group. I've got
Yes,
a
please.
folder of revision notes for things that I've been slowly creating for you guys. So I'll share it. There's a nice crib sheet in there for fertility. Okay, so who's next?
Yeah, I think I'm up there next.
Okay.
Yeah, happy.
Ali, would you mind doing the time for us, please?
Yeah. Yes, I'm doing it now.
Thank you. Sammy, are you ready?
Yeah, go ahead.
So we're going to carry on with the same scenario. So
Okay.
how would you do a vasovasostomy?
Yeah, vasectomy, this procedure done under general anesthetic, either microsurgical or macrosurgical. It's done patient in a properly consented anesthetized patients in supine through a midline or bilateral transverse incision, using ideally a loop. The two ends of the vas being delivered using a vasectomy reversal clamps. Both ends get dissected and freshened up until a fresh semen or secretions identified. One of the ends, the testes ends samples sent off for semen analysis and storage if possible, and then end-to-end anastomosis and the free tension using 9/0 or 8/0 Vicryl or PDS, achieve hemostasis and closure in layer, and yeah, that's and the scrotal support and local anesthetic towards the end.
Okay. How do you do an epididymovasostomy?
Epididymovasostomy, I didn't done normally when there is a factor, intraoperative factor to suggest that vasovasostomy is not doable, such as increased gap, or there is a lot of scarring in the testis end vas. Doing it is either end to end or end to side. Again, either microsurgically or macrosurgically. Microsurgically is thought to be better, and again using the same stitch, either PDS or Vicryl 9/0 or 8/0, and closure layer with local anesthetic and scrotal support.
Okay. So you've got a new patient. He's 35. He attends your clinic with his 30-year-old partner. They've been trying to conceive for 2 years. There are no female gynecological factors. What are the important features to elicit from the clinical examination?
Adil, I would have seen him in my clinic. The female parameters already being excluded. I will focus on whether how many years they have been trying for, primary or secondary factors of fertility, male factors, in particular, in history of cryptokidism, any previous inguinal scrotal surgery, recreational drugs, gonadotoxins, any previous radiotherapy in the pelvic area, comorbidities, and fitness for surgery. This is from the history. And then I will move to examination with a chaperone present. I want to note the secondary sexual characteristics, inguinal scrotal area for any scars to suggest any previous surgery. The external genitalia, in particular, look for the size and the consistency of the testes, the presence of the bars, presence of the epididymi, and any abnormalities such as varicocele. And note his height and weight and BMI.
Okay. When you examine him, he's got normal testes bilaterally, and you can palpate the vas and epididymi bilaterally. What investigations would you organize?
I will organize biochemical investigation first. This is early morning testosterone, LH and FSH.
Why do you do early morning testosterone?
Testosterone has the diurnal variation, so it tends to be higher at the peak in the early morning before 11 o'clock, and it then goes down. Yeah.
Okay.
So this is the biochemical investigation. I will organize an ultrasound scan for the testes, scrotal ultrasound. I will counsel him about semen analysis. That's a 2 semen analysis 3 months apart after 2 to 5 days of abstinence. And then we'll organize virology. That's a hepatitis C, B, and HIV in view of future storage if needed later on.
Okay. So have you got a pen?
Yeah.
So his semen analysis come back. He's got a volume of 3 mils.
Yeah.
There's no sperm, and he's got a normal FSH.
Yeah.
What are the possible diagnoses?
So no sperm, and so he got a normal volume, no sperm, and normal FSH. So he has got azospermia, so either obstructive, non-obstructive. And yeah, from non-obstructive, then it will be few possibilities and obstructive.
So what are the possible diagnoses?
He got azospermia. I would like to note his pH and fructose, just to decide if it is obstructive or not. But he's currently azospermic, either obstructive or either non-obstructive.
Okay. How would you investigate obstructive azospermia?
Obstructive obspermia, guided by the semen analysis, will, if the semen analysis suggests it is a proximal obstruction suggestive of for example, like ejaculated duct obstruction, I will perform an ultrasound scan to look for the size of the semen vesicle, and also an MRI scan to look for Mullerian duct presence, suggests abdominal obstruction.
Okay. Why are you doing an ultrasound?
Sorry, truss ultrasound to
You're going to do a truss and an MRI.
Well, yeah. I will do one. The MRI scan is more sensitive. However, due to the availability of the MRI and costs associated with it, I will do the truss ultrasound scan first.
Okay. So on your imaging, there's no obstruction. What would you do next?
If there is no obstruction on imaging, I will request then an MRI scan to have more idea about the presence of evidence of obstruction, such as Mullerian duct cyst.
You don't think you can see that on an ultrasound?
You can see that on ultrasound scan. If it's not present, then I guess that the MRI scan might not be helpful. Then I can counsel the patient about vasogram.
Okay. How would you do a vasogram?
Vasogram done endoscopically, with the presence of fluoroscopy, using omnipaque contrast, and try to inject the contrast into percutaneously through the vas. And
percutaneously, really?
No, I'm not. I would be guessing.
So have a think about how you might do it.
Yeah. Okay.
Okay. Let's move on. You've done the vasogram. Actually, you do know how to do it. It's not percutaneous. You deliver the testes, mobilize the vas, and then you put a small butterfly into the vas and inject some contrast and take some images.
Yeah.
It's all normal.
1 minute left.
So the vasogram is normal, the MRI is normal, the ultrasound is normal. What would you do next?
This will be no evidence of obstruction, so I will treat him as non-obstructive azospermia.
What in his clinical history makes you think it's obstruction, and what in his history and examination makes you think it's non-obstructive?
From the examination, if non-obstructive, I will expect to see a small atrophic testes, was suggestive of like a primary testicular failure. If it's normal testes with presence of low volume and low fructose, low pH semen analysis, that would suggest of obstructive.
That's 10 minutes.
Okay. So you started off a bit well, and then you went a little bit haywire.
Yes.
So the vasectomy reversal, I think it's 10-0 actually.
10.
It's a very, very small suture. Then is pretty good. It needs to be tighter though. It needs to be really focused in the history and then really focused in the examination as well. But I think you got most of the things. The investigation was fine. The possible diagnosis actually did really well there. Most people don't get that it could be non-obstructive. How do you investigate? I would do a truss or an MRI. You're right. You can do a vasogram if you're really convinced that it's obstructive. What you do with a vasogram, oh, I told you already, didn't I? So it's not percutaneous. And you can have intratesticular obstruction.
Okay.
If you have that, you will not see any obstruction on any of your imaging. So just bear that in mind, that sometimes you can have obstruction, but no obvious cause. Now, what's against this being non-obstructive, Azo, is the fact that you don't need his pH, really. It's mainly the clinical examination that you would base it on and the hormones. So obstructive azo, they will have normal volume testes. You might be able to feel that the epididymi are dilated depending on where the obstruction is, and they'll have normal hormone profile. With non-obstructive, you would expect their FSH to be high, their testes to be small. So this guy's probably got obstruction. He could have non-obstructive azo, but it's more likely to be obstructive, this guy. So don't be thrown if there's no obstruction on any of your investigation, that it's definitely not obstructive. But the crux of it is, what are you going to do next with this guy? He's got no sperm and he wants to have a baby.
Yeah, I've noted, his wife age was 38, 39?
30.
So, 30, okay. So will be, again, depends on, there is a couple factors. He is young, she's young, but she's 30. So bear that in mind. How many children do they want to have? If they want to have like multiple children, I think reconstructions might be.
Reconstruct.
There isn't
Sammy,
anything.
This is where Sammy. This is where you're not thinking. What are you going to reconstruct in this patient? You found no obstruction on anything.
No, there isn't any.
How are you going to reconstruct him? What are you reconstructing?
No, there isn't. There isn't. So it will be a surgical sperm retrieval technique.
Yeah, exactly. Of course it is. And at this stage, it doesn't matter if he's obstructed or not obstructed. Well, it does a little bit. But you're going to work on the premise that he's probably obstructed, but you haven't been able to find the obstruction. It may be intratesticular, is what you'll say to yourself. So I'm going to stop there.
Okay.
Because it's time for the next person to be tortured.
Can I just ask, is it worth offering this patient a testicular biopsy to see if it is intratesticular obstruction?
No, because you won't be able to prove it, and you won't be able to do anything about it, and it doesn't change your ultimate management, and you won't find it. A biopsy doesn't tell you that it's obstructed. You just have to say it may be an intratesticular obstruction. You haven't been able to see anything. It's more likely to be obstruction. However, I've seen patients who are non-obstructive have normal testes, and you've just got to find sperm. That's what you've got to do.
Okay.
Yeah.
Okay. Thank you.
That's okay. Who's next to be tortured this evening? We're going to kiss scenario. Sammy, would you time, please?
Yeah.
Ali, tell me when you're ready.
Okay, I'm just putting the timing on.
Okay.
Sorry, just okay.
Surgical sperm
So
retrieval.
the different techniques are testicular sperm extraction, which is percutaneous epididymal sperm aspiration, TC, Micro-TESE, and MISA. So with so if there is evidence of sperms in the epididymis, you can perform.
How do you know if there's evidence of sperm in the epididymis?
So if I know the gynecologists, they tend to do the percutaneous epididymal sperm aspiration through the epididymis is percutaneous.
When is it okay to do that, and when is it not okay to do that?
I'm not sure. I think as urologists, we don't think it is the right thing to do at all.
It's not really an answer. Okay, come with the other ones.
Not sure. So TC's testicular it's done for you can also do this procedure with microscopically, so microscopic TESE, which gives you a better yield of sperms for a smaller area of seminiferous tubule extraction.
Not quite true. Okay, go on.
And then MISA can be done if at the same time of offering vasovasostomy in view of offering IVF and in cases of vasovasostomy reversal, vasectomy reversal, sorry.
Okay, so you've mentioned TESE and Micro-TESE. What are the advantages and disadvantages of each of those?
So Micro-TESE is done with a microscope. So the one of the disadvantages is it is a bit more labor intensive and requires more instruments like microscope. It will require a readily available I'm not really sure if it's a geneticist who looks into it, or is it a
embryologist.
Embryologist. The other advantage is with Micro-TESE, the seminiferous tubules can be isolated, and if it shows good evidence, a good presence of good quality sperms, then they can be extracted. While in TESE, healthy-looking seminiferous tubules from different areas of the testes are extracted for sperms.
Okay. How can you describe how you do a TESE and how you do a Micro-TESE?
Okay. So just been told off here. I'm sorry. Can you repeat the question?
Oh, how would you do it? Describe how you do a TESE and how you do a Micro-TESE.
I'm sorry. I'm not sure about this.
Okay. We're going to move on. So you've got a new patient. He's 25. His partner is 27. They've been having difficulty conceiving for 2 years. They're both fit and well, but he reports that he has a dry ejaculation. how would you establish the type of anejaculation he has?
So I would like to see him in the andrology clinic. Would like to ask about the duration and severity of his symptoms, if this is primary or was he able to have this ejaculation prior to this, if he is on any medication, any previous surgeries, any history of trauma, any spinal surgeries or spinal trauma they might have had, any pelvic radiotherapy or lymph node, retroperitoneal lymph node dissection, followed by any medication for neurological disorders or psychological disorders that he might be on, followed by a detailed history of his past medical, past surgical history. And I would like to examine him, would like to look at his secondary sexual characteristics, his BMI, a focused examination of his genitalia, looking at the penis, ureteral meatus, and bilateral testes, vas, epididymis, followed by investigations, which will include semen analysis, post-orgasmic urine microscopy to look for any evidence of sperms in there. And if clinically indicated, I would also like to ask for an ultrasound scan of his genitalia as well, testes and vas and epididymis.
Okay, so what are the types of anejaculation that you're aware of?
It can be divided into primary or secondary. So yeah, primary or secondary. Secondary could be related to trauma or any previous surgeries to the spine, or any medication that might be causing this. Could be psychological as well. And primary is likely going to be due to obstructive pathology of the obstruction of the genital tract.
Okay, so what are the causes of anejaculation?
So causes of anejaculation could be ejaculatory duct obstruction, could be secondary to medication like tamsulosin, so retrograde ejaculation, could be secondary to spinal surgery or radiotherapy or to the pelvis, retroperitoneal lymph node dissection that causes injury to the nerves, and chemoradiotherapy to the pelvis.
Anything else you can think of?
No, I'm sorry, I can't think of anything else.
Okay, what are the fertility issues associated with retrograde ejaculation?
So the fertility issues is inability to conceive. That's one of the major problems.
Okay, how would you obtain sperm in somebody with retrograde ejaculation?
So I would ask him to avoid orgasm or sexual intercourse for 3 to 5 days. In the interim, I will give him some oral bicarb to alkalinize his urine. I will advise him to empty his bladder before ejaculation, and then after ejaculation, would want him to collect all his urine sample in a bottle and send it to the lab as soon as possible. The sample is going to be centrifuged, and the sediment is going to be aspirated and put under the microscope, and sperm retrieval done that way.
Okay, if that fails, anything else?
For retrograde ejaculation, if that fails, then this patient can have surgical sperm extraction.
Okay, what are the pros and cons of the treatment strategy that you mentioned with bicarbonate?
So the advantage is alkalinization of the urine. Which is acidic urine is spermicidal for the sperms. To alkalinize it, we are likely to get a healthier sperms, which can be used for artificial insemination. Sorry, can you repeat the question again? And cons. So the cons is that that this sodium bicarbonate is be palatable, and people tend to complain of some gaseous.
Okay. How much time have you got? Is that time?
10 minutes.
Oh, okay, fine.
It's done.
That's perfect. We've got start of our next scenario. So let's just go back. Not too bad that time. But Ali, you've got to listen to the questions. You're not listening to the questions. You're sometimes answering the next question. Okay.
I think we've made a big mistake of being here because the music is on and this lady was telling us off halfway through this exam, and I got completely distracted.
Oh, don't worry. Where
it's
are
completely
you?
my fault.
Where are you?
We're in Frere's Brew Frere's. It's like what is this place called? It's like Beefeaters in Bromsgrove.
Why are they telling you what? Oh.
Yeah, because apparently everybody can listen to our discussion and it's very rude.
Oh, jeez, I need to get a life. So the different types of surgical sperm retrieval. I've just sent you the, what's it called? I've sent you a link with the folder. It's got lots of different goodies. Feel free to share it with anybody you like. So I'm going to talk to you very quickly about the different techniques. So there's PESA. You do that in an obstructive azo. It needs the epididymis to be dilated. Otherwise, you will be unsuccessful. So the epididymi has to be dilated for you to be able to shove a needle in. It's percutaneous. Then you've got a MESA, which we spoke about already. That's the one you do during the vasectomy reversal. Then you've got a TESA. Again, that's gynae like to do that one. You just stick a needle through the skin into the testes and you try and aspirate some sperm. You should really only do that if it's an obstructive azo. Yeah. The problem with a PESA is that if you're shoving a needle into the epididymis, as you can imagine, you might get some surrounding inflammatory change. And if you're planning to reconstruct, it can make the reconstruction difficult. So that's why we don't really like gynae to do that, because they don't really think about things like that, because they don't reconstruct things. So if it's an obstructive azo, a TESA would be better, because then you just put it in the testes, you avoid the epididymis, which is where you might want to do some reconstruction. So if you're planning some reconstruction, a TESA would be a better option than a PESA.
So but TESA done by the gynae as well?
Yeah.
Okay.
So yeah, so TESA, aspiration, PESA, aspiration, both done by gynae. Yeah.
Okay.
Makes sense?
Yes.
Then a TESE is the one we like to do. That's because we operate on testicles. Again, you're really doing a TESE if you think there's obstructive azo. Yeah.
Yes.
If it's an obstructive azo, there's a very good chance that there's sperm in the testes. So you can do it. The way we do it is you make a small scrotal incision. Yeah, deliver the testes, make a small window, make a small incision in the tunica. You get lots of gubbins out, cut, flush. You give it to your embryologist and they'll say, yes, there's lots of sperm here. We're going to take it away and freeze it. Yeah.
Yes.
If it's a non-obstructive azo, the gold standard is a Micro-TESE. And the way you do that is, again, deliver the testes. You'll do as much as you need to. So when you're doing a Micro-TESE, usually these are small scarred up testes. So you deliver the testes and then you bivalve the testes. You make it, you cut and you open it out like an open book. Yeah.
Yes.
You bring your microscope in and then you're looking for areas of tubules that look moist and plump, that may have harbor some sperm. And then you'll dissect those areas and you give that to your embryologist in the hope that there's some sperm.
Okay.
You might end up doing a bit more dissection with the Micro-TESE, and you may give them smaller samples with a Micro-TESE. So you've got to worry about, these are small testes, which probably don't function very well. So you should check. There's a risk of hypogonadism.
Okay.
With these sort of patients.
With non-obstructive or
yeah, when you do a Micro-TESE, yeah. So you've got to check their testosterone probably at some point afterwards. Make sense?
Yes, yes.
So the pros and cons of the TESE versus a Micro-TESE. A TESE is much less dissection. You basically just make a hole, just make a cut, and you'll get lots of tubules, jumping out. So you can give a much bigger sample to your embryologist, okay. And the success rate is probably higher because if it's obstructive, they make sperm, it just can't get out. And it doesn't take as long to do the operation. Anyone can do it, really. Don't say that. With a Micro-TESE, you've got to get the microscope in. You may be dissecting for 1 hour, 2 hours. You'll do one testicle, and if you don't find any sperm, then you're going to do the other side, and you're trying, to look and find some areas where it might be a patient who has no sperm. If you've ever seen it, sometimes you open it and it's all just scar tissue, and you're trying to find something that might resemble normal tubules. And you can spend hours doing that. So it takes much longer, and it's slightly more risky because you're doing it in small testicles. Then the types of anejaculation. So there's primary and secondary, as you said. And then the causes, don't forget, they can have psychological. It's a really poorly understood area. And the way you sort of went around the houses. I told you all the history, but you still reassessed them, which you didn't need. I wanted you to tell me how you figure out what sort of anejaculation it is. And basically, you want to know if this guy can he ejaculate. So you get him to do a semen analysis, and then you do a post-orgasmic urine analysis as well, because you want to know, is this somebody who never ejaculates, nothing ever comes out because he just doesn't produce anything, or is this somebody who does produce sperm, but he's got retrograde ejaculation? That's really what you're trying to figure out, yeah? And you do that with the semen analysis and the post-orgasmic urine. Then the causes, I've got in my notes, psychological and neurological. So I think you got most of them, but it was all jumbled up. It wasn't nicely structured, Ali. So you can talk about surgical. So I've got psychological and neurological. So the neurological ones, post-pelvic surgery, or RPLND, or retroperitoneal surgery. So we cause a loss of anejaculation with LNDs, but the colorectal guys do as well, because they do a lot of bowel surgery, especially in your inflammatory bowel disease patients. So don't forget that. Don't forget radiotherapy. And then the one that everyone forgets about is diabetes, because they get autonomic neuropathy. Yeah.
Okay.
So a lot of them, a lot of the diabetics, the vas does not contract because there's basically damage. There's neuropathy of the small vessels that control contraction of the vas. So they just don't ejaculate anymore.
Okay.
That's actually really common. And then the drugs, antidepressants, alpha blockers. I think you mentioned the alpha blockers. And then the fertility issues. retrograde, it's going to be really difficult for them to have a spontaneous child. So they're probably going to need assisted reproductive techniques of some sort. They can have things like they can have bicarbonate where you alkalinize their urine, but the success rate isn't great. It's very unpalatable for patients, but it is an option. The other thing that's that you can do is you can, I don't know if it's widely accepted, you can put bulking agents into the bladder neck if it's somebody who's post TURP and they're young. Might be something that they might want to consider. Does that all make sense?
Yes, yes.
In terms of how you obtain sperm. For the most part, they're probably going to have surgical sperm retrieval.
Okay. Okay.
If they've got retrograde. Yeah?
Okay. Yes.
Okay. Who's next? Who's next on the torture train? Are things making sense? Some of these are really difficult scenarios, to be honest. That's why I've thrown them in.
We wanted to do one more, but
Okay.
we just feel like we just go and hide in the car, so we don't have to get the toll.
Okay.
Will you be able to just like 2 minutes to 1 minute just
Yeah,
to go
yeah,
out?
yeah, absolutely.
Yeah.
Absolutely.
Thank you.
I'm going to go to the bathroom while you guys are changing sides.
So sorry, just we had to find a place to hide, sitting in the car now.
Hi guys.
Yeah.
Hello.
Okay, I've got a cracking case for you. You like this last one. Okay.
Let's do this.
Are you ready, Sammy?
Yeah.
So you've got a 30-year-old chap who has a 3-year history of difficulty conceiving. So he's fit and well, no obvious risk factors, no female factors, and he has a normal scrotum. What investigations would you organize?
Early morning testosterone alongside LH, FSH, ultrasound scan for his scrotum, semen analysis, 2 samples 3 months apart, and virology screen.
Okay, so I mentioned that there were no female factors. What are the female factors for infertility?
What general female factors?
Yeah.
General female factors, if she had a previous gynecological surgery, her fertility reserve, any previous menstrual cycle abnormalities, any hormonal treatment that she had in the past, any radiotherapy. That's generally, yes, I would expect.
Okay.
Oh, and recreational drugs.
And say that again?
Recreational drugs.
Okay. How do you obtain a sperm sample? What instructions would you give the patient?
It's a semen analysis of two samples, two samples 3 months apart, at least 2 to 5 days. Abstinence has to be ideally given on site within 30 to 40 minutes. If that's not possible, it has to be delivered immediately to the lab in a warm pocket, you know, like either in a pocket, but it has to be delivered immediately to the lab within 30 to 40 minutes.
Anything else?
Yeah, just avoid abstinence for 2 to 5 days, and yeah, 3 months apart.
The patient wants to know if he can use a condom.
Oh yeah, so you have to avoid any condom or spermicidal medications beforehand.
Okay, so have you got a pen?
Yeah, yes.
I've got some results for you. So his semen analysis, the volume is 0.5.
Yeah.
There's no sperm.
Okay.
The pH is 6.9.
Okay.
And his fructose is 6.
Yeah.
His FSH is 2.5.
Okay.
His LH is 4.
Okay.
And his testosterone is 16.
Testosterone is 16. Okay.
Yeah.
Interpreting these results, he has got a low volume semen, low volume semen with no sperm. So that's none, and low pH and low fructose. So that indicates he's got obstructive azospermia. His hormonal profile is normal, so there isn't any hormonal abnormalities. So I will investigate him and manage him as a non-obstructive azospermia.
What source of obstructive azo? What sort of azo?
Obstructive azospermia.
Okay. What are the possible
Yeah,
causes of obstructive azospermia?
Possible causes is either can be proximal or distal. Proximal, i.e., like a seminal vesicles level, such as ejaculatory duct obstruction. Distal obstruction, that's either at the testicular epididymis level, such as a scarring or post-surgery, or post, previous vasectomies, for example. So these are and congenital absence of vas difference.
Okay, so how are you going to work out what the cause of this chap's obstruction is?
So I will start with ultrasound scan to look for the seminal vesicles, if they are distended or not. If that's not suggestive or not conclusive, I will move to MRI scan to look for any signs of Mullerian duct cyst, which can cause obstructions. Then I will counsel him, depends on the results, about future management.
Okay. Is there anything in his semen analysis that points to a diagnosis?
His low fructose is 6. So he's fructose deficient, which means that his seminal vesicles, like the obstruction at the seminal vesicles level.
Okay.
And his volume, 0.5.
So the your scans have shown that he has a Mullerian duct cyst. How are you going to manage this?
I need to counsel him about cystoscopy and transurethral resection of ejaculatory duct obstruction. This done under general anesthetic. Ideally, I will have a radiologist and embryologist on site. I will counsel the patients first about need of surgical sperm retrieval technique at the same time. During the procedure, I will perform cystoscopy, then identify the ejaculatory duct and resect and deroof. Sorry, before that, I would have injected methylene blue and the truss guidance, and I will deroof cystoscopically until I see a blue dye presence or visible.
Okay, so what would you write on the consent form for this chap?
It will be cystoscopy and TURD, so transurethral resection of ejaculatory duct, plus or minus surgical TESE, like a surgical sperm retrieval technique. I will put in the consent form.
Are you going to do that at the same time?
It can be done at the same time if we aspire. Depends on the technical facility available on site, or presence of embryologists on site as well. If we aspirate the seminal vesicles at the time and there is no sperm visible, that means the outcome of the transurethral resection will be very low. Hence, the patients will benefit from surgical sperm retrieval technique. It can be done in different settings, but if it's visible, if it's feasible to do it at the same time, it can be done.
Okay, that's not a bad answer, actually. Okay, anything else you're going to write on the consent form? Risks?
Risks, counseling about risks. Obviously, the benefit is to achieve conception, to help with conception. Risks, general and specific. General, that's including bleeding, infection, and anesthetic complication. Specific to this procedure would be risk of scarring, urethral stricture, risk of chemical orchitis, risk of failure, need additional treatment in the future. Risk of retrograde ejaculation, risk of incontinence, and risk of further fertility treatment in the future. That's generally, and I will provide him with the BOWS information leaflet about this procedure. Okay,
that's the end of my fertility questions. How did you guys think it went?
Yeah, that's
I think it went well, and I was questioning why you were offering sperm retrieval until you answered, your last answer, and I was like, fair enough, I'll give him that.
Yeah,
I think it went well.
I have to say, I thought that too, but I think it's a good point. You probably would discuss that with him. You would arrange the embryologist before, so you'd have counseled him in clinic that, just in case it's not successful, that you might just, at the same time, he's under an anaesthetic, you might as well try and get some sperm from his testes that you can freeze as insurance. So I think it is sensible. The only other thing I think we've covered most of the scenarios that could come up for fertility. The only other thing I would say is with anejaculation, as opposed to retrograde, anejaculation where it's a neurological cause, you could try electroejaculation as well, which is where you stick a probe into the rectum to stimulate the sympathetic nerves leading to ejaculation, and then when they ejaculate, you collect the sperm. Sounds like a disgusting thing to do. To be honest, I've never.
Sami is quite familiar with this.
Pardon?
Sami is quite familiar with this.
Oh, is he? I bet. So that's a really good option for your spinal cord injury patient. Yeah.
Right. Yes.
That's the only other thing I can think of that could come up that we haven't specifically discussed. I will maybe make up a scenario at some point for that. Do you guys have any questions?
No,
that was
thank you. I think it was really good.
Yeah, the infertility. Yeah, we've done because that's the part we get a bit confused, but that was good that we covered.
So whatever they ask about fertility, always throw in donor sperm and adoption. There are always options for management. Yeah.
Okay.
You're going to ask something, Sami?
Yeah, I was just gonna say, like in my head, like you can always offer like a sperm surgical retrieval techniques as a combination with assisted reproductive technique as well. Like if there is a couple going
Assisted.
for
So assisted reproductive technique is that's IVF essentially.
yeah.
So you don't have to combine it with surgical sperm retrieval. So
Okay.
I'm just going to talk to you very quickly about IVF because I sometimes forget to go through that. So you've got different types of IVF. So you've got IUI, ICSI, and I think there's a third one that I've forgotten the name of. So ICSI.
IUI.
So IUI, the chap has good quality sperm. So essentially what they do is they mix the sperm and the egg together and then they implant it. Yeah.
Okay. Yeah.
With ICSI, the man does not have good sperm quality.
Okay.
So this will be sort of patient where you've performed some sort of surgical sperm retrieval.
Yeah.
And you've got to inject that sperm into the egg and then implant it.
Yeah.
So that's assisted reproductive techniques. So you can have.
Can I just confirm? It's intrauterine insemination,
Yes.
IUI, where the issue is it's good quality sperm, basically. And then the other option is IVF, which is again good quality sperm.
So they're both IVF.
They're both IVF. Okay.
Yeah. And they're both assisted. Anything where a couple isn't going to conceive naturally is assisted reproductive. It's a assisted reproductive technique. Does that make sense?
Yeah. There's a last one: intracytoplasmic morphologically selected sperm injection.
Okay.
IMSI.
So you can get patients where they've got genetic abnormalities.
Yeah.
So you will pre-select out the egg or the sperm without those genetic defects. Commonly it might be cystic fibrosis gene or maybe sickle cell gene. So you pre-select those genes out before, so you wouldn't use the egg or the sperm with those genes, genetic abnormality. Makes sense?
Yeah.
Let me just double check that, because I only learned about that recently, guys, myself. Let me just double check.
If it's poor quality sperm, we are doing ICSI. If it's good quality sperm, we're doing the IUI. Yeah.
Okay, no, that isn't strictly true. Let me just so the one I told you about is, I think it starts with a P.
Is that the pre-implantation?
It's pre-implantation something. So IMSI is where you select sperm with the best morphology used.
Okay.
And it's a modification of ICSI.
Okay.
And so you increase the magnification of the sperm to more than 6,000 times. That's what I've got in my notes. So it's a modern type of ICSI. So like a really good form of ICSI.
Yeah. Okay.
And then, so IVF, which we always talk about, this is all IVF really. So IUI, IUI, sperm into uterus, timed around ovulation, and then IVF, you will stimulate the ovaries, and then you'll recover the eggs, and then that's mixed with sperm.
Yeah.
And then once the sperm has fertilized the egg, they'll then put it back into the woman.
Okay.
So the developing embryo is incubated for a couple of days and then placed back into the uterus. Does that make sense?
Yeah.
Whereas with IUI, they're not stimulating the woman. So they're just going to time placement of the sperm around ovulation.
Okay.
So it will actually, sorry, I tell a lie. So it will either be during her natural cycle or with stimulation, whereas IVF, it's hyperstimulation.
Hyperstimulation. Okay.
Yeah, I don't think you'll need to know it in like
No, in detail,
tiny details, but you need to have a rough idea of. I think they've asked it a few times in recent years. Does that make sense?
Yeah.
Yes.
Yeah.
Okay.
Thank you. But it was very good. Yeah. Very
Thank
good.
you. Thank you very much. Yeah, it was good.
It was
Very,
this
very
fertility
good
stuff.
for me.
Yeah.
Yeah.
Yeah, I did fertility because people get scared about fertility.
Yeah.
I think next we should do penile cancer because that's the other thing people get scared about.
Yes. I still got that. I saved it. The one that we draw together in the theater.
Oh, did you?
The
That's
algorithm.
the drawing.
Yeah. Oh, that made a huge sense. Like I read it now. Like okay, it's easy.
Thank you for keeping it. Thank you for keeping it with yourself.
No.
Not sharing it with me. Thanks.
I've saved it. Yeah, I've got it.
So,
Man.
I'm just thinking, when can I? Are you guys doing anything on the 1st or the 2nd of October?
No, we haven't got any. That's Saturday, Sunday. We don't have anything booked. No.
How about second?
Yeah, should we pencil the 2nd?
Yeah.
Yes, please.
Okay,
Yes, please.
I'll put you guys in practice.
Yeah.
With
What time you want, Ayo?
what time's good? I sort of think maybe I can give you guys the whole of Sunday, or at least until you lose the will to live. What time do you guys want to do?
We don't mind. We got it by you.
No, you guys will do.
Last time I think we did like a afternoonish time.
Okay.
Like a,
Should we
you know,
say
12 till 1, 12 till.
what was that?
We did like a 12 till 1, 12 till 2, something like that. But
Okay,
yeah, it's whatever works for you.
12 is a good time. Does that work for you, Ali?
Yeah.
Yeah.
12 o'clock. Yeah, that should be fine.
Okay, I've put it in the diary. And we'll use this link again.
Yeah.
And because we've got a Sunday,
Okay.
we can do the whole thing. So we'll try and get through all of penile cancer because that's the other one that's scary, and then we'll do some.
Can we actually do it at 1 o'clock? That's
Yeah.
please, if you don't mind. Thank you.
Yeah.
Thank you. 1 o'clock.
Yeah,
Thank
no worries. I'll change it. 1 o'clock.
Thank you very much.
Okay. So we'll do penile cancer and we'll make a start on benign andrology. There aren't actually that many things they can ask you in penile cancer.
Mm-hmm. Yeah.
So,
Okay.
it's just the fact that you guys get scared.